Welcome back, everyone. Thank you for joining tonight. Tonight's session will be on procedures for assessment. And I just want to let you know that we have a questionnaire we'd like you to complete, and I put that in the chat. I'll put it in a couple more times during today's session. I also put the slide deck for today in the chat, and we'll repeat that. And want to remind you that next month's session will also be a week later because of New Year's. And so next month we will be meeting on January 8th, and it will be on best practice considerations. So with that, I will get the slideshow up and running and turn it over to Jennifer Eggert.
Hello and welcome back, everyone, or if you're new to joining us, welcome. I anticipate that everyone is busy with this time of year. So if you have a friend or a colleague that you're working with that can't join us today, be sure to spread the word that, again, these recordings will be available. As Dawn had mentioned, we are talking about procedures for assessment today. So I always like to begin these with just a little bit of a review where last time we had talked about a team approach and that the team approach is vital when working with students with PFD. If we can go to the second slide there, Dawn. And we talked about this interaction, this triad really between the student and caregiver or caregivers, outside medical providers, and then school district personnel. I want to remind you all again on the next slide here that when we're talking about thinking about the roles and responsibilities of all of the many individuals who are part of these teams, is that we need to keep in mind the scope of practice and competency, and that this is something to consider as it will look different for each team. And this can change over time as individuals gain experience, participate in mentoring and training, and as we participate in role release where somebody is trained. Again, another reminder that competency is not a single course or certification. So this is something that we want to, of course, keep in mind as we're working with these very, very special population here. So on slide 4, the other thing that I thought was really important to review as we were going into talking about procedures for assessment was that we had looked at, first of all, the 4 phases of a normal swallow. And Dawn, if you click on that, the words should pull up there. So the 4 phases of a typical swallow would be first the anticipatory phase, where you're getting excited for the food. I hope that all of you were excited, for those of you who celebrate Thanksgiving, for all of that delicious food. The oral phase, where the food is actually in your mouth and you are manipulating it through tongue, teeth, jaw, lips. The pharyngeal phase, where the bolus or that ball of food begins to travel into the throat, and then the esophageal phase, where there is that movement of the bolus into the stomach, eventually for digestion. So that is the 4 phases of a typical swallow that we look at. Now, on the next slide, we will both review and expand upon the very first thing that we talked about here when we met back in September, which is the diagnosis of PFD, or pediatric feeding disorder. Now, we had talked about PFD being defined as impaired oral intake that is not age appropriate, lasting at least 2 weeks, and associated with 1 or more areas of dysfunction. And we talked about the fact that PFD is a diagnosis that is made in the absence of eating disorders, such as bulimia or anorexia, and a pattern of oral intake that is not due to a lack of food. So any financial pieces to that, or related to cultural norms. So for example, a cultural norm that you may see that may limit intake during certain times is as we come up on different holidays. For example, students of Islamic faith at a certain age may participate in fasting. So one of the things that I really want to drive home today again is that I want to expand your knowledge of PFD and give you actual tools that you can use that will help you to identify this. This isn't going to be an hour of me saying, okay, look at the tongue, look at the teeth, look at the jaws, look at the lip, let's look at a swallow study. This is me giving you tools that you can use that will actually give you all of that information to tell you what you are looking for. Because I think that's what's most nerve-wracking to individuals when they start thinking about feeding and swallowing as the schools is, I don't know what to look for. And I respect that that can be very nerve-wracking because this is certainly an area where we can do more harm than good when we are looking at safety. So in looking at the diagnostic criteria here, I just want to expand a little bit on this slide. For medical, you may see individuals who have cardiorespiratory compromise during oral feeding. Think about kids who maybe are on oxygen, kids who have any sort of cardiac or respiratory involvement where their breathing may be impacted. Thinking about aspiration or recurrent aspiration pneumonia is certainly a medical piece that we would be aware of. In the nutritional domain, we look at malnutrition, again, not due to a lack of food, but due to individuals being malnourished due to their poor intake skills. We see kids who are specifically nutrient deficient or significantly restricted intake of one or more nutrients resulting from decreased dietary diversity. We do see this a lot in our autism population, especially in terms of oftentimes it's the fruits and vegetables because of the textures. Some dairies may be very hard for individuals. Again, our ASD population tends to feel safest and most comfortable with the hard, crunchy sort of, we call them the brown foods, the crackers, the chips, those types of foods. Individuals who have a reliance on enteral feed, so that would be like a G-tube or oral supplements. So think about like your Pediasure or your Ensure to sustain nutrition and or hydration. In the feeding skill domain, pediatric feeding disorder could fall under anyone who needs a need for a texture modification of liquid or food, whether that be for a safety reason, again, or due to sensory requirements of the child, use of modified feeding positions or equipment, and then use of feeding strategies. And this is one of the things that we're going to talk about that's so important is that you actually ask to observe the typical caregiver feeding the child, or atypical caregiver feeding the child, because caregivers are so instinctive. They are amazing. They do things without even thinking about it. And so if we go in and we feed a child, we just start doing things and the kid isn't eating. Well, one of their caregivers comes in and starts feeding them, and we realize instinctively they're doing XYZ, which is supporting that child in being successful. In the psychosocial domain, we look at active or passive avoidance behaviors by the child when being fed. That can be anything such as turning away. I recently was working with a child who literally would just sit in his high chair. He was older. He was a school-age child, still being put into a high chair, and he would just put his hands behind his back and go like this. And it was really frustrating to me to see him doing that because it was just such a passive behavior of, for him, 5 years, well, 4 years of oral feeding, of literally just being trained to eat this way. Inappropriate caregiver management of a child's feeding and or nutrition needs, disruption of social functioning with a feeding within a feeding context, and the disruption of caregiver-child relationship associated with feeding. And again, these can be quite dramatic. We've seen individuals, kids who have been, I did see a child who was restricted to a single room for most of his life until he was removed by Child Protective Services, and really had the psychosocial understanding of very specific foods. He had his nights and days mixed up because of the situation in the home, and really didn't understand that feeding was even a social moment in his day. It can also be very, very mild things such as clean your plate. How many of us grew up being part of the Clean Plate Club, right? So let's go to the next slide here, where we talk about, again, a little more specifically, what are some of the signs and symptoms that we're looking for? Because again, I am expecting you coming here to say, I don't even know what I need to know. What should I be looking for? So looking at each of the symptoms by the domain is going to help us again to know what to look for. So in looking at the medical domain, we had previously talked about things like labored breathing, or needing a modified diet because of aspiration or aspiration pneumonia. So specifically, what are some of those other things that you're looking for in the medical domain? Kids who have labored breathing with or without feeding, your vocal folds open and close, as we talked about, every time you swallow. If you are breathing very, very, very fast, your vocal folds cannot keep up with that pace. And so that puts you at risk for aspiration. A body at work of breathing will always be a body at work and breathing. It will trump everything else. Color changes in lips or face when eating or drinking. And it can be anything that's very mild, such as something that's a very light blue, to changing red, to getting dusky, to getting pale. Sweating when eating or drinking is a sign of a medical concern. Gurgly or squeaky sounds with or without feeding. Reoccurring upper respiratory infections can certainly be of concern, as are, of course, those non-verbal communicative pieces that we see with kids crying, arching their back, coughing, grimacing when eating or drinking. I was working this morning with a child, and even just touching a food, he did what I asked him to do, which was to put the cracker into the cup, but he went like this. And you could just see him grimace the moment he touched and relaxed the minute he had released. Any suspected food allergies, multiple formula changes. We see a lot of kids whose parents will say, I had to switch to like 3 or 4 different formulas before I finally found something that they didn't spit up all the time. Vomiting, kids who never seem hungry, or physical discomfort when eating or drinking. On the next slide, we'll talk about the same signs and symptoms, but by the domain of nutrition. Kids who are unable to eat or drink enough to grow or stay hydrated, insufficient or too rapid of a change in weight or height. And lots of times this piece at least is being caught by GI. When we have kids on tube feeding, sometimes those tube feedings work a little too good. And all of a sudden we have a skinny child who all of a sudden has become rather skewed to the other end. And so then we have weight issues on the other end of the spectrum. A lack of certain nutrients in their diet again, need for nutritional supplements. And I'm not talking just a multivitamin, like everybody pretty much can benefit from a daily multivitamin, right? Reliance on particular food for nutrition. So if you can only eat certain foods, the need for any of those enteral feedings. Constipation is a big one. And again, we see this a lot in our autism population. If you are stopped up, you aren't going to feel hungry. And limited dietary diversity for age, too few fruits and or vegetables, limited or no protein source. Again, we say protein, not meat. And I think that that's something that everybody's pretty commonly knowledgeable about nowadays, is that there are a lot of sources of protein that aren't meat, and too few foods eaten on a regular basis. So again, I work with a child right now. He has 5 foods: apple juice, milk, graham crackers, oatmeal, and McDonald's French fries. And it has to be McDonald's French fries. And so he certainly has some very specific limited dietary diversity that we are working on trying to get him healthy and safe. So on the next slide, we'll look at feeding skill. And this is where I think people often get a little bit nervous, like, okay, what am I looking for? So again, there's that breathing piece, right? Labored, noisy breathing, or that gasping when you're swallowing. It sounds sort of like that gasping for air. Coughing, choking, gagging, or retching. Please know that parents, I'd say more than 50% of the time, are going to come to you and say, my child chokes. And more than 50% of the time, the child is actually not choking. And so I will say to them, wow, choking. They actually stopped breathing, like they stopped breathing and you had to do the Heimlich or call 911. And they'll say, oh, well, no, they don't do that. And I'll say, oh, so it sounds like they were coughing and gagging. Yeah, that's what they did. So I just use that as an opportunity to provide that education, because coughing and gagging are actually protective. They're good things. If our body is coughing on something and gagging on something, it's saying, whoa, there is a response here that has to happen to keep my airway safe. Now, it could also be sensory in nature, but choking is a very dangerous thing. Gurgly or wet breaths, loud or hard swallow. So if you swallow and you can hear the gulp, again, individuals who are unable to eat or drink enough for optimal growth. really short meal times. So those kids who stuff it all in. And I'm not talking the kid who's like excited because it's the first snow day of the year and they want to get out on the playground and climb on the snow hills, right? Excessively long meal times, anything over 30 minutes is problematic in terms of caloric intake because then you start burning more calories than you're taking in. Need for thickened liquids, need for special food or modified food textures. And again, there's those specific strategies for positioning or equipment. Now, specifically again, for some feeding skills for an older child, 12 months of age or older, I have on the side there that grazing between scheduled meals. We all know those kids who just walk around their environments and somebody's always putting something in their mouth because that's the only way that they know how to eat. That is not uncommon that we see that. Is that ideal? No. Is that optimal? No. Is it typical? We do see that. Refusal to eat, drink, or swallow certain food textures. This is a big one. The needs for distraction to eat, such as screen time. Screen time is huge. So lots of times we'll see parents have, again, instinctively said, or caregivers, I need to get my child to eat. You are correct. We do want your child to eat. And so they figure out that they can distract their child with a screen. And with that distraction, then becomes a whole new problem that we have created. Now the child cannot eat without screens. The need for excessive praise, threats, bribes, difficulty chewing age-appropriate foods. Again, not developmentally appropriate, age-appropriate. That is something very specific that was put into this diagnostic criteria, is that a 7-year-old should be able to chew what a 7-year-old can chew, despite whatever developmental differences they may have. And the inability to eat in new or unfamiliar situations. And then finally, we have the psychosocial domain where individuals are unable to come to or stay with the family at meals, those kids who leave the table. Oftentimes that's a sensory piece, but sometimes it's that they don't understand mealtime routines. Refusal to eat what is offered or to eat at all. Disruptive mealtime behaviors, throwing, tantruming, screaming. Unable to eat with others present at mealtimes. They have to have certain specific people, certain specific setups, stress, worry, or fear during meal times. The caregiver having stress, worry, or fear when feeding a child. This is huge. If you remember the very first webinar that we did, we watched that video of that family, and those dads were so stressed trying to feed their child. It was very traumatic for them. The presence of bribes, threats, or yelling at mealtimes. There's that need for distraction and or rewards again, and the unpleasant mealtime interactions between a caregiver and a child. So how do you screen for this? What do you do? What are you looking for? We've kind of talked about it, but how do you do this? Well, here's the introduction to all of this. We've been doing feeding and swallowing with kids for many, many years. We've also been doing articulation and language with kids for many, many, many years, right? If I asked you right now to put into the chat, which you don't have to, the name of our favorite articulation screener, or your favorite articulation test, or your favorite language test, or your favorite phonological assessment test, you could do that without even thinking about it. In terms of feeding and swallowing, these are all, Courtney said the tills. Thank you, Courtney. These are fairly new to us though recently. Right? Somebody said the Hodson, the Gifta. Yeah, I mean, we could just shoot them out, right? You could fill the chat. We could be here all day. Now throw out some screening tools for me in terms of feeding and swallowing. You're probably going to have to Google. You're probably going to have to think about it. So I want to give those to you today so that you have them. These all are evidence-based. They have been researched. They are found to be very, very good tools that we should be using. So the first one comes from Feeding Matters, and it is called the 6 questions subset. And on there, it's basically a yes or no question with the exception of how long it takes to feed a child. Dawn's going to keep screening down. If you want to, you can have the parent actually go to the website here and fill out the long form of this, and they will get an answer. So that's what I wanted to show you there. Dawn, let's go back to the slide and show the screener though. So the screener here though, you can very easily see the first question is, does your baby or child let you know when they are hungry? Do you think your baby child eats enough? There's that length time, how many minutes? Do you have to do anything special to help your baby or child? Does your baby or child let you know when he is full? Based on the questions above, do you have concerns? And the answers that are red flags are actually in orange there for you. So if you have two or more of your answers in orange, that would be a screener for we need more information. So let's just go back to screening versus assessment 101 for 1 second, right? Screening is pass fail. You pass the screening, yay, congratulations. We don't think we have any concerns. You quote unquote fail the screening, and we say we need further assessment. And so again, this is where it's a team approach. We need further assessment. Where is that going to happen? Possibly at an outpatient setting, possibly at a local hospital that you work with. But again, it's that reasonable step to say we need more information. Okay, next slide. Now, the next number of assessments or screeners that we're going to look at are from the Feeding Flock, which is a fabulous organization that provides a lot of information on feeding and swallowing. So these are the Feeding Flock tools. The first one that I want to talk about today is the Child Oral and Motor Proficiency Scale, otherwise known as the CHOMPS. Again, here's my gift to you, my holiday gift to you. This is parent-reported assessment, caregiver-reported. So you don't have to be doing this, but you do it with the caregiver. It measures observable eating, drinking, and related motor skills relied upon for solid food eating. And this one is from 6 months to 7 years of age. So again, we know that caregivers are experts on their children. Now, of course, somebody else could fill this out too. You could maybe do a compare and contrast. But this is a great tool to use, along with the PD Eat, which is the next one there, which is the pediatric eating assessment tool. Again, this looks at infant and child behaviors during liquid and solid food feeding from 6 months to 7 years of age. Again, it is a parent-reported assessment tool. So Dawn, if you just click on that link there for a second, what you will see there on your end is that all of these tools here are on this one link. And so you can scroll down, you can view the link. Let's just look at the PD Eat for a second there, Dawn. If you click on View Tool. And so there you go. So it will take you to that. If you keep scrolling down, then you can actually view the resource, and it will get you very easily into what you need to do to ask these questions. Again, what's so great about this is that it's all online. So you could sit with a caregiver and do it. You could virtually join in and do it together, whatever works best for that individual. Okay, so let's go back to the slides here. Thank you, Dawn, for being such a master at navigating all of this so smoothly. And on slide number 12 there, we have some additional assessment tools that really look at the family impact. Remember, we said that in the psychosocial domain, pediatric feeding disorder can be diagnosed by stress to the caregiver. Maybe the kid is like, hey, I'm not stressed out at all. Like somebody's shoving food in my face and I'm ignoring it. I'm not eating. We do have those kids who are like, I'm just not going to eat that. But the parent is really stressed. So these two tools here, the impact of feeding on the parent and family scales, or the feeding impact scales, and the family management measure of feeding, or the FAM-FEED, are two measures that impact the child's feeding on parent and family. And they look at how the families manage the child's feeding difficulty, and these go from birth to 18 years. Again, these are both parent-reported assessment tools. So this is just, again, a fabulous way for you to feel secure in your assessment, that you know that you're using something that's evidence-based, and that you're really getting into the expert, the caregiver, in getting some of this information. Okay, let's look at slide number 13. Now, another thing that I want you to all think about is consideration for age. So some of you may say, well, I work in a middle school or high school. This is maybe not a concern of mine because these kids are probably already identified versus the preschool, early childhood children who you're thinking, wow, like these kids are coming in and they have all this information. We're working on understanding what's going on with them. But remember, these early childhood preschool kids may still be acquiring skills. And the preteen and teenage students may present with what we call a decline in skills. Length and growth negatively impact swallow function. So if we think way back to when we look at infants, infants are born very compact, right? And they have what we call physiological flexion. They're here, their hands are up at their mouths, their necks are pretty much like non-existent. Their little ears are touching their little shoulders. We have a lack of space in the oral cavity. We have a lack of space pharyngally. Mother Nature has set it up perfectly. That swallowing for them is easy, efficient, and safe. However, as that length increases, we see less and less of those safety features, and we see more and more inclination for there to be problems. So we often see kids, and I've seen this many times, where we start hitting puberty, and all of a sudden feeding skills that we thought were stable begin to decline. So please, if you're on here and you have a colleague in the middle school or high school, if anything, share this slide with them, because this is a really important point that we want you to remember, that this again can change across the lifespan, especially in those growth years. Okay, so on slide number 14, we're going to talk a little bit about the assessment roles and responsibilities. And we're going to go through just like we did previously in our last presentation. And so you will see on every slide in blue, I have what we had shared last time. What were the roles and responsibilities in terms of being part of the team? Now what we're going to do is expand upon that and say, what is their role in terms of an actual assessment? So as you remember, in terms of the caregiver or student, we wanted them to share the knowledge of the feeding history and current feeding needs, provide pertinent medical history, and share any goals and concerns, including those cultural considerations. Now, this is their number one thing that they need to do. We need to have them demonstrate what mealtimes and feedings look like. Now, I can say that this has become so much easier because of technology. Parents will oftentimes just pull up a video on their phone and they go, oh, you want to see it here? I'll show you right here. And they pull up like 3 or 4 clips. They're like, look what happened on Thursday. Look what happened last week, Saturday. Look at what grandma said was happening. And so we really can use technology to our advantage. We do have kids who cannot participate in mealtime in the schools because of an environmental piece. That's something that they're learning. That's a goal that they have. So take advantage of technology, either Zoom into that household or have that caregiver go ahead and get you some recording of what is going on. Again, caregivers are so instinctive. They are amazing. They are experts in their children, and they are doing things that they don't even realize they're doing. And I think we should not only observe them to see what they're doing to support the child, but also to give them a pat on the back and to say like, wow, did you realize that X, Y, and Z is really a technique that we have to teach people? And you're doing this in and of yourself. Like, how amazing is that? How in tune with your student are you that you figure this out on your own? And I think that's just a wonderful moment to share with a parent or a caregiver. Okay, so we're going to pass it on to my friend Anne, one of my fellow speech therapists, who's going to talk about the assessment roles and responsibilities of the speech pathologist. So go ahead, Anne, take it away.
Okay, thank you, Jen. And the resources that you shared are just amazing. So I just want to reinstate how incredible they are. And I'll talk about another one too. But so as far as the speech pathologist goes, many times in my history anyway, I was the primary point person for the feeding and swallowing concerns. And the assessments really are ongoing. There's never it's not just cut and dry. You go in, you observe, and that's it. You really have to continue to observe that student and check and make sure that certain things are working okay, and take a look at things as they change for the individual. It can either be, their oral sensory needs can change too. And then another huge part of what we do as a speech pathologist is the interpretation of medical records. Inquiry to see if a swallow study was done or not. And if it was done, reviewing that report really thoroughly and looking at the recommendations that were made by the feeding team. I also accompanied parents when they went to Children's Hospital in Milwaukee to go for a swallow study, because a lot of times they were a little anxious about it or nervous. So in that way, I could find out kind of firsthand what was what was going on and what I needed to reinforce when we got back to school and to assist the families and the staff. And then also participating in the development of feeding plans, just kind of making sure that, as Jen said earlier, one of our main concerns is safety. And so putting together a plan that includes safe swallowing, preparing the foods in a way that the individual could take them so that in the safest manner possible. That could mean blending foods, it could be thickening liquids, a variety of different things, maybe some strategies for biting and chewing, putting the food on the side molars to encourage the chewing patterns. So those are things that we have a role in. And then training team members on the implementation of the feeding plan. And that was always a huge part. I would go into the classrooms during lunchtime or during snack time and make sure that the staff felt comfortable with following through on the recommendations that were made and that we would follow, these safe swallowing procedures. Another tool that is very helpful, and I recently just used this one, I was called to, one of our new speech pathologists called me to come and do a swallowing kind of observation with her. So I used the ASHA Pediatric Clinical Swallowing Evaluation Template and just used it as a guide. This child was a grazer, and this little girl moved all around the room, and we had to really follow her around to see what she was doing with the food, realized that she was holding the food in her mouth, not necessarily chewing it right away. So just, using this as a guide to see maybe what we could recommend for the family. The family was already thickening liquids, and she didn't even have a swallow study. So as Jen said, caregivers can really come through with some things that on their own, just based on their observations. So always keeping in communication with the families too is huge. But this is just a nice little checklist. It gives you an idea of what you're looking for, what to look for, and then just making some recommendations toward the end. Looking at, here some safety precautions, checking the ones that would apply. And a lot of these were really, really good. I thought it was a real thorough tool and just wanted to make sure that that everybody knew about it and knew that you have it totally accessible to you. So that's about it. Dawn or Jen,
So
can you
thank
think
you,
of anything
Anne.
else? Okay.
So I just want to reiterate what Anne said about the ASHA Pediatric Clinical Swallowing Evaluation Template. That is something that was in the works for a while and again is now published for use. It is much more extensive than the screeners that I had shared with you previously. Again, we want you to have a variety of tools and resources that you can use. So as you gain skills and knowledge, or as you are looking to gain skills and knowledge, you have access to this. I think that this clinical swallowing evaluation template is a fabulous, more in-depth thing that you can look at to say, okay, what are some of the specifics that I'm looking at? Because it really does break things down. So it's just a great resource to have, again, to add to your toolbox and to add to your learning. So let's talk about the assessment roles and responsibilities of occupational therapists. Again, on the left there in the blue box is what we had talked about previously as far as the general roles and responsibilities. And in the green box are some of the new pieces that we have. And then we're going to also do this with physical therapy. So I'm going to hand this over to Michelle, who's going to cover both of our motor therapists for us. Again, as she's hopping on here and getting her mic unmuted, reminding that, occupational therapy is really going to include this interplay of physical, cognition, emotional, environmental, and social cultural factors, and providing the effective services for feeding and eating and swallowing dysfunction. So, Michelle, do we have you on and ready?
Yeah, right
Oh,
here.
there you are. Perfect.
Yeah.
Good.
Yep. So I want to just sort of recall back to the beginning when Jennifer was talking about that scope of practice and competency issues. OTs generally included in our scope of practice are things like cultural components and cultural humility around all the types of therapy that we're providing, settings, social opportunities, developmental status, environmental factors, neuromotor, all these things can generally fit into what our scope of practice is. And then we need to think about it as it relates to our competency related to feeding and eating. And one of the important things that we will have an influence on is that upper extremity function and hand-to-mouth manipulation for self-feeding. So those fine motor skills that are required, and sometimes we'll think about them developmentally as well. We have to include everything sort of together. They layer on top of each other that are required to go from that raking grasp to grasping a utensil, and then eventually being able to scoop. So those are the ways in which we can impact and have some influence on what's going on with the feeding and eating and how we might assess it. Now, important to remember is that we do not, as I think, was that Anne that was just talking? Yep, Anne was saying, talking about a checklist, we do not need to use standardized norm reference tests to review this. In fact, oftentimes it's better to use criterion referenced assessment tools or checklists that are evidence-based, like the PD, the Pediatric Evaluation of Disability Inventory, and the school function assessment are both tools that can really guide, oh, sorry, looking at the question in the chat, but I'll let them answer that later, that can really guide the OT to cue them into the specific areas to evaluate and give some really nice data to go forward with. And then for PT, we can switch to the PT. PT, generally speaking, they're really addressing that postural and positioning area of assessments. So the ability to achieve the position of proximal postural control that allows upper extremity and oral functioning for eating. So they're going to need that postural control to be able to sit up and identify what is the most effective way for them to complete the task of eating, feeding, and swallowing. Because sometimes the child does need to be in a slightly, not fully sitting up 90-90-90 position to be able to adequately access the swallow and moving the food around in their mouth. And yet we also have to consider the motor needs of getting the hand to the mouth. So it is a dance that does require all these different disciplines to contribute. And they might use also the PD or the school function assessment along with other types of checklists or tools like that.
Thank you, Michelle. So perfect. All right, let's move into the nursing responsibilities. Unfortunately, our nurse is on the road and very busy, so I'm going to cover that. But in terms of what their assessment role is, feeding assessment is really not within the scope and practice of registered nurses. So, so what we will see our registered nurses, though, doing is looking at an assessment of health conditions, any of those pieces that may be impacting their feeding, obtaining the orders for tube feedings, assisting with explaining how difficulty with swallowing places the student at risk of aspiration. I loved one of those very first webinars that we were on. Louise so appropriately and gently reminded us all that, nurses are busy. But they're a different kind of busy than we are in the rooms and in the classrooms. And so they may actually have the time to call a caregiver, answer a phone call, like, what would that be like? And at the moment, and be able to have some of these conversations. So it's just such a great piece that we can use them for. And then documenting in the IEP how receiving adequate nutrition supports the student's ability to attend school and work on IEP goals. So yeah, so that is something that the nurses can certainly do to help us, even though they may not be specific to the feeding assessment, they're looking at that health assessment, which is just as vital. And our educators and paraprofessionals, again, are so important as pieces of this team where they are reporting and sharing data and intake and observed behaviors. Again, we see these kids from moments in times, and we may not see them at ideal moments in times, right? Our schedules are busy, your schedules are busy, but those paraprofessionals and educators, regular ed, special ed, who are with them for significant amounts of times are so important, again, to giving us that information on what they're seeing. And not only on what they're seeing, but seeing it at different times of the day and in different situations. Okay. In terms of nutrition, again, Maggie, our dietitian, is out and about today, but it's really good to have that information on portion sizes and menu choices, options, and varieties when you are meeting with families, caregivers, students. There may be items that students may be able to eat. There may be items that students are able to eat with some modification. There may be items that students should definitely not be offered, either from a safety standpoint or from a standpoint of knowing that that could be something that the sensory properties of could send that child into quite a negative experience. So having the information on what's being offered at meal times is really a great thing to have at our fingertips. Most schools will have those lunch menus at least like a month at a time. I know some districts do it week by week, and being able to coordinate with the nutritionist on that. In terms of the administration's roles, again, we had previously talked about them supporting team members working with PFD, serving in that mediator or liaison role, and being aware of feeding and health plans. But really another step up is providing those of us who are in these roles with guidance regarding legal paperwork for communicating with outside providers and even within our districts, right? So we have to remind ourselves that this is a team, not just a team within our school, a team within our district, a team within our community. And so there is some paperwork that's involved in that. And we're going to talk about that a little bit when we talk about that next month, when we talk about optimally how to do this, because we do want to make sure that we're covering our backs. We do want to make sure that we are protecting everything related to HIPAA, related to FERPA, all of those different things that are legal for students, because it is their privacy and their rights. So I'm just going to remind you again that Dawn put in the chat the questionnaire regarding your knowledge of PFD and your current comfort level midway through the series. We would love to have that information. And while you're looking at that link in the chat, I also want you to start throwing some information in the chat. First of all, do you have any questions right now? I said to Dawn when I sent this to her, I said, I feel like this is one of the most important webinars that we're having. I feel like this information is optimal for everybody to have because it gives you what you are looking for. And that is really our goal here, to support you. Again, not to make you all experts in feeding and swallowing or PFD, but to give you the support you need to be able to support these students in participating in the schools. So I'm not seeing any questions in the chat, but I loved some of the questions that came up. But what I would love to do now is to take a little survey. And what does assessment look like in your school or your district? What are you doing? Who's in charge of what? Are people even doing assessments in this area? Some of you may put in this chat nothing, and that's why you're here. So I'm looking forward to seeing this chat blow up here. I'm going to assume that everybody's busy typing. Not that you're ignoring Dawn's questionnaire, but you're going to come back to that. And nothing that I'm aware of. Okay, thank you, Taylor, for that. Taylor is saying nothing. Assessments of feeding. Yes. What are you doing in terms of assessments of feeding? Aubrey wanted clarification. Shelley said nothing that I'm aware of. This is not surprising to hear. And so it's really reassuring that you are all here.